Good afternoon, everybody. Welcome. This is the first of the ASHNR's educational webinars, and we've titled this Talking Heads and Necks. My name is Christine Glastonbury. I'm the chair of the ASHNR Educational Committee, and on behalf of Callie Robson, our president, and all of the ASHNR members and our executive committee, I'd like to welcome you all to our first session. Before we get to the lecture, I do want to remind you that we've opened our abstract site. Erica, can you go to the next slide, please? We've opened the abstract site for the ASHNR meeting. So this is our first virtual meeting, which is in September, the same dates as the original meeting, but please go ahead and submit your abstracts. Believe it or not, we opened it yesterday. We already have abstracts being submitted. So please do that. Moving forward with our webinars, I would like to remind you that you can get CME credit for this webinar. This is an ASNR website. If you go to that after the webinar, you can get CME credit for being at this webinar. So today's first webinar, their learning objectives were posted. There are no disclosures from any of the speakers or moderators, but I would like to thank very much Dr. Gul Moonis and Dr. Ben Huang, who have both graciously accepted an invitation to lead off our very first webinar. And I'd like to very warmly welcome all of the ASHNR members and all of our international members, especially our ESHNR members. And thank you very much for joining and welcome.
All right, so at this point, I'm going to introduce the speaker for the day, and that is Dr. Ben Huang. Ben is Associate Professor of Radiology at University of North Carolina. He's a native Chapel Hill, born and raised. And in fact, his entire education has been at UNC Chapel Hill, except for his medical school at Duke. After his training, he went on staff at the same institution and has been a fellowship director in neuroradiology since 2014. He's a gifted speaker and orator and has given this talk at our national meetings. And head and neck imaging and temporal bone imaging is his passion and interest. And so we're really lucky that he agreed to give this talk to kick off our ASHNR webinar. So without further ado, we can get the lecture started. Erica?
Hello everyone, and welcome to the ASHNR webinar on temporal bone anatomy. My name is Benjamin Huang. I'm a neuroradiologist from the University of North Carolina, and in this session I'll be reviewing the imaging anatomy of the temporal bone. Now, the temporal bone is a region that I think a lot of people approach with some trepidation because it is anatomically complex. My hope today is that I can simplify things a bit, and in doing so, make you more comfortable at looking at temporal bone studies. This lecture will also set the stage for subsequent webinars by Dr. Curtin and Dr. Robson in the coming weeks. So here are my objectives for today's lecture. By the end of this talk, you should be able to distinguish between the three main functional units of the temporal bone, namely the outer, the middle, and the inner ear. You should be familiar with the normal contents of the middle ear cavity, including the ossicles, the facial nerve, and the middle ear muscles. And finally, you should understand the distinction between the bony and membranous labyrinth of the inner ear and know the structures that make up each of them. So we'll start our discussion with a gross overview of the temporal bone. Now, if we were to deconstruct a person's skull and extract the temporal bone from it, this is basically what we'd see from the outside. These are netter drawings of the temporal bone, including a lateral view and a bottom-up view. The temporal bone, of course, makes up the lateral portion of the skull and skull base, and it's classically divided into four parts. The squamous portion, which is the thin plate-like portion that projects superiorly and makes up the inferior part of the lateral skull. The mastoid portion, which is the aerated part of the temporal bone located behind your earlobe. The Petrous portion, which is a pyramidal-shaped structure that includes the otic capsule and Petrous apex and articulates medially with the sphenoid and occipital bones. And finally, the tympanic portion, which is a curved plate that makes up the anterior wall and floor of the external auditory canal. Now, in addition to these four main parts, there are two named processes arising from the temporal bone. The zygomatic process, which forms the posterior portion of the zygomatic arch, and the styloid process, which projects inferiorly and serves as an attachment site for various ligaments and muscles in the deep neck. Now, this is all well and good, but unfortunately, these gross anatomic distinctions aren't all that useful for conceptualizing the anatomy of the temporal bone on cross-sectional imaging. Rather, what we do as radiologists is to divide the temporal bone into its three main functional units. That is, the outer ear, the middle ear, and the inner ear, each of which plays a unique role in our ability to perceive sounds. In addition to those three main functional units, we can also add the mastoids and the Petrous apex to our search list. These are portions of the temporal bone which are not directly involved in hearing, but which do play host to their own unique pathologies. Now, for today's talk, I'm going to focus mainly on these first three regions, which are critical to our ability to hear, and we'll cover each of them individually. In addition, at the end of the lecture, I'll briefly touch on the anatomy of the Petrous apex. So going from outside to in, we'll start with the outer ear, which is made up of the auricle and the external auditory canal. Together, they work to collect sound waves and to funnel them to the tympanic membrane. The auricle is the portion of the ear that you can see when you look at the side of someone's head and is realistically most easily evaluated on physical exam rather than imaging. So I'm not really going to spend any time reviewing it today. The external auditory canal is basically the air-filled tube extending from the auricle to the tympanic membrane. And it is itself divided into two parts, an outer cartilaginous portion, which makes up the lateral third, and an inner osseous portion making up the remaining 2/3. Now, the cartilaginous portion is made up primarily of elastic cartilage anteriorly and inferiorly, with the superior and posterior walls made up mainly of fibrous tissue. In addition to providing structural support, the cartilage of the EAC acts as a potential barrier to disease spread, but notably it does contain a couple of vertically oriented clefts known as the fissures of Santorini, which are presumably present to help give the EAC some flexibility, but unfortunately also provide a potential route of disease spread from the outer ear into the deep soft tissues and skull base, which is classically seen in the setting of malignant otitis externa. The osseous portion of the EAC is made up of contributions from the squamous temporal bone superiorly, the mastoid temporal bone posteriorly, and the tympanic portion of the temporal bone anteriorly and inferiorly. And these join to form a complete bony ring that we can usually best appreciate in the sagittal plane, as we can see here. Now, in most individuals, you will see a complete and uninterrupted osseous ring, but on occasion you may see a focal defect along the anterior-inferior aspect of this ring medially. This defect is known as the Foramen of Huschke, or Foramen tympanicum, and it essentially represents failure of the tympanic segment to completely fuse with the rest of the temporal bone. Now, this foramen is actually normally present at birth, and it usually closes by around 5 years of age. However, in about 5% of temporal bones, it can persist into adulthood, in which case it's generally thought of as a normal anatomic variant. Now, that said, a persistent foramen of Huschke can, in rare instances, allow tissue from the temporomandibular joint or the parotid to herniate into or to fistulize with the EAC. In addition, it's also thought that a patent foramen of Huschke may predispose individuals with EAC infections to the development of malignant otitis externa by allowing the infection or organisms to spread directly into the infratemporal fossa. Now, moving out of the EAC, let's jump to the other side of the tympanic membrane and talk about the middle ear, which is also referred to as the tympanic cavity. Now, the middle ear occupies the space bounded medially by the bony capsule of the inner ear and laterally by the tympanic membrane. We traditionally divide the middle ear into three main compartments: the epitympanum, the mesotympanum, and the hypotympanum. The mesotympanum is basically the portion of the middle ear that lies directly medial to the tympanic membrane. The epitympanum is located just above that and is bounded superiorly by the tegmen tympani, which is the thin plate of bone that separates the middle ear from the middle cranial fossa above. The lateral border consists of the scutum and this vertically oriented plate of bone known as Kerner septum, which forms the boundary between the petrous and squamous portions of the mastoid air cells. Finally, the hypotympanum is the portion of the middle ear lying inferior to the tympanic annulus and generally makes up a very small portion of the tympanic cavity. Note its relationship with the jugular bulb, which sits directly beneath the hypotympanum and can occasionally herniate into the middle ear cavity if its overlying bony plate becomes dehiscent. Now at the level of the epitympanum, the middle ear communicates with the mastoids posteriorly, which we can see on this axial CT image. I'll draw your attention to this hourglass-shaped space here between the inner ear medially and Kerner septum laterally. The anterior part of the hourglass is the epitympanum, while the posterior portion is the mastoid antrum. The waist in between them is known as the additus ad antrum, which is the major highway through which things like cholesteatomas can spread from the middle ear into the mastoids or vice versa. And here we have just such an example of a cholesteatoma arising in the lateral epitympanum and spreading upwards and backwards through the additus into the mastoid antrum. Now the area in the inferolateral aspect of the epitympanum has a name. It's known as Prussak space, which specifically refers to the space bounded laterally by the scutum and pars flaccida of the tympanic membrane and medially by the neck of the malleus. This is where the majority of acquired middle ear cholesteatomas arise due to its association with pars flaccida, which is the most floppy portion of the tympanic membrane and is therefore the part which is most susceptible to the formation of retraction pockets. Now let's move a little bit more inferiorly to the level of the mesotympanum, where we'll find another route of egress from the middle ear known as the protympanum, which is an anteriorly projecting space situated between the carotid canal medially and the mandibular fossa laterally. This space represents the posterior bony portion of the eustachian tube, which of course connects the middle ear cavity with the nasopharyngeal airway. And this is an important relationship to remember because it explains why a tumor of the nasopharynx can present with middle ear or mastoid symptoms. This is a case of a patient who presented with a right mastoid effusion, which was due to a large nasopharyngeal tumor obstructing the eustachian tube at its distal end. So with those areas of the middle ear as our backdrop, let's now focus on some of the contents of the tympanic cavity, which basically consist of 3 bones and 3 soft tissue structures. The bones are the 3 ossicles, while the soft tissue structures include 1 nerve, specifically the facial nerve, and 2 muscles, the Tensor Tympani and the Stapedius. And I'll spend some time reviewing each of these. We'll start with the ossicles, which are a trio of bones that form a chain whose basic function is to amplify sound and transmit it from the tympanic membrane into the inner ear through the oval window. The ossicles in order of conduction are the Malleus, the Incus, and the Stapes. If you have a hard time remembering their order of articulation or the window into which they conduct, a helpful mnemonic to use, particularly if you enjoy Japanese food, is MISO, which of course stands for Malleus, Incus, Stapes, oval window. So let's now take a look at each of the ossicles in a little bit more detail. Starting with the malleus. The malleus is a club-shaped bone spanning the epitympanum and mesotympanum. The superior end of the malleus consists of an oblong head, which is located in the epitympanum and articulates posteriorly with the incus. Just beneath the head is a short, narrow neck, which in the axial plane can be identified as the more anterior of the 2 dots that you'll see as we transition from the epitympanum to the mesotympanum. There are 3 bony processes that emanate from the neck, including a short lateral process, which attaches to the tympanic membrane, a small anterior process where the anterior malleal ligament attaches, and a longer inferiorly directed process known as the manubrium or handle. The lateral surface of the manubrium also attaches to the tympanic membrane, and its inferior tip indicates the location of the umbo, which represents the most depressed central region of the eardrum. Now, the incus is the second ossicle in the chain and is located posterior to the malleus. It consists of a central anvil-shaped body, which articulates with the head of the malleus and gives off two bony processes. In the epitympanum, there's a cone-shaped short process which projects posteriorly, and which, along with the head of the malleus, creates the classic ice cream cone, with the head of the malleus making up the scoop of ice cream and the incus body and short process making up the cone, with the malleoinguinal joint in between. In addition, the incus body gives off a thinner, inferiorly projecting long process, which on this axial view at the level of the malleus neck represents the second, more posteriorly located of the two vertically oriented dots. The end of the long process takes a medial 90-degree turn to become what is known as the lenticular process, which is the part that articulates with the head of the stapes at the incutio-stapedial joint, which we can see nicely on both the coronal and inferiorly located axial images. Now, the stapes is, of course, the final bone in the ossicular chain. It is a bone shaped like a stirrup and includes a small head, also referred to as the capitulum, which articulates laterally with the lenticular process of the incus. The head is joined by a short neck to two limbs, or crura, which project medially and attach to a flat oval-shaped foot plate, which sits on the oval window membrane located along the lateral aspect of this vestibule. And this is, of course, where sound vibrations enter the inner ear from the middle ear cavity. Now, in addition to the ossicles, there are a few soft tissue structures that normally live in the middle ear, one of which is the facial nerve. On a temporal bone CT, it's quite easy to find and to follow the course of the facial nerve. These are axial images going from superior to inferior. Starting at the top, we can see a small canal coursing anterolaterally from the IAC between the cochlea and the vestibule. This is the canal for the labyrinthine segment of the facial nerve. At the end of this canal, we'll find the fossa for the geniculate ganglion, which is where the first genu of the facial nerve is located. From there, the nerve continues posteriorly within a thin-walled bony canal that courses along the medial wall of the tympanic cavity underneath the lateral semicircular canal. It then has a second genu where it takes a 90-degree turn downward to descend through the mastoids. Let's now trace out the facial nerve in the coronal plane. This first image, located most anteriorly, slices through the cochlea, which we can recognize by its characteristic spiral shape. If you look just above and lateral to the cochlea, you should see two dots, which are sometimes likened to the eyes on a snail. The medial dot represents the labyrinthine segment of the facial nerve, and the lateral dot is the proximal tympanic segment. Now, as we move more posteriorly, we can follow the tympanic segment as it courses beneath the lateral semicircular canal. And finally, just posterior to the second genu, we can see the entire mastoid segment of the facial nerve as it descends and it exits the temporal bone at the stylomastoid foramen. Now, the second facial nerve genu resides in a part of the temporal bone, which is known as the retrotympanum, which is home to a few structures that it's worthwhile to mention. In this location, the nerve normally resides in a triangular-shaped bony ridge known as the pyramidal eminence. The pyramidal eminence is also home to one of the muscular structures of the middle ear, namely the belly of the stapedius muscle, which is the smaller of the two middle ear muscles. In some patients, you can actually see the stapedius tendon coursing from the pyramidal eminence to insert on the stapes neck, as we can see here. There are also two important recesses located on either side of the pyramidal eminence. The more laterally located space is known as the facial recess, which is an important surgical access point into the middle ear. This is an example of a patient who's undergone cochlear implant surgery. Notice the typical course of the electrode, which travels from the mastoid cavity through the facial recess into the middle ear, and finally into the cochlea through the round window. On the other side of the pyramidal eminence is a space known as sinus tympani. The importance of sinus tympani is that it is a common location for cholesteatomas to be missed during middle ear exploration. This is because surgeons can't actually see into this region using traditional mastoid or transcanal approaches. So it's important for them to know ahead of time whether or not the sinus tympani may be involved by a cholesteatoma. Now, the other muscular structure in the middle ear that you should be familiar with is the tensor tympani muscle. This is the larger of the two middle ear muscles, and on CT, the tensor tympani is fairly easy to identify. In the axial plane, it appears as a linear soft tissue structure running along the roof of the protympanum. At the posterior end of the muscle, there is a small bony process known as the cochleariform process, where we can see the tensor tympani tendon make a 90-degree turn and course laterally to insert on the neck of the malleus. On coronal images, we can usually find the tensor tympani as the third dot situated just beneath the snail's eyes of the facial nerve that I mentioned just a few moments ago. So that takes us through the middle ear. Let's now turn our attention to the last of the functional regions of the temporal bone, that is the inner ear, which resides in the petrous portion of the temporal bone and is composed of two parts, the bony labyrinth and the membranous labyrinth. The bony labyrinth, also known as the otic capsule, represents the osseous shell that encloses the structures of the inner ear. It includes the cochlea, the vestibule, the semicircular canals, and the vestibular aqueduct. The membranous labyrinth, on the other hand, consists of a network of interconnected fluid-filled structures containing a special type of fluid, which is known as endolymph. These structures reside within the bony shell of the otic capsule and include the cochlear duct, the utricle and saccule, the semicircular ducts, and the endolymphatic duct and sac. In addition to this, there is a space located between the membranous labyrinthine structures and the outer shell of the otic capsule, which is filled with a different type of fluid known as perilymph. And as it turns out, most of the fluid that we see in the inner ear on our 3D fluid-sensitive MR sequences is actually made up of this perilymph. While there are techniques available for differentiating the perilymphatic and endolymphatic containing spaces on MRI, our commonly used steady-state sequences like KISS or Fiesta-C aren't going to be able to distinguish them. So today I'm going to primarily approach the imaging anatomy of the inner ear based on these bony labyrinthine divisions. And we'll start with the cochlea, which is the most anteriorly and medially located structure in the inner ear, and as we've already seen, has a characteristic spiral-shaped configuration, making roughly 2 3/4 complete turns around a central bony axis known as the medullus. The medullus contains the terminal portions of the cochlear nerve and the spiral ganglion cells. If we were to section the cochlea along the medullar axis and look at one of the turns in cross-section, we'd basically see 3 fluid-filled chambers. The small chamber in the middle is known as scala media, representing the cochlear duct, which you'll recall is one of the structures that makes up the membranous labyrinth and is therefore an endolymph-containing space. On either side of scala media, there are 2 larger perilymph-containing ducts, scala vestibuli anteriorly, and scala tympani posteriorly. We can often see these 2 ducts separated from one another by a faint line on either CT or MRI, which represents the osseous spiral lamina. Keep in mind, though, that these 2 perilymph-containing spaces do communicate with each other at the cochlear apex at a site known as the helicotrema. Now, I don't want to get too much into detail on how the cochlea actually works, but the basic idea is that vibration of the stapes against the oval window creates pressure waves which are propagated through the perilymph of scala tympani around the helicotrema into scala vestibuli and then out through the round window, which opens into a small inferiorly directed recess in the middle ear at the lateral end of the basal turn of the cochlea. These pressure waves are also transmitted to scala media, which activates specialized epithelial cells in a structure known as the organ of Corti. This produces action potentials that then travel to the brainstem through the fibers of the cochlear nerve. The cochlear nerve itself normally enters the cochlea through a small canal at the base of the medialis, which you should be able to identify on a normal CT. This canal should measure at least 2 millimeters in width. If it's smaller than that or is absent, you should question the possibility of cochlear nerve deficiency and consider recommending an MRI. Now, on your high-resolution MR sequences at a comparable level, you should be able to see the cochlear branch of cranial nerve 8 coursing right into the base of the medialis and the vestibular nerve situated right behind it. It's often quite helpful to reconstruct your images in a plane perpendicular to the axis of the IAC, which gives you a down-the-barrel view that looks something like this. The canal should contain 2 dots anteriorly and another pair of dots or a vertically oriented bar posteriorly. The anterior superior dot is the facial nerve. The anterior inferior dot is the cochlear nerve, which should normally be about the same size as the facial nerve. And the posterior bar or dots will represent the superior and inferior divisions of the vestibular nerve. So let's now take a look at a not-so-normal case. These are CT and MR images from a child with profound right-sided sensorineural hearing loss since birth. Starting with the CT in the normal hearing left ear, we can again see a normal, patent, bony cochlear nerve canal. And on the corresponding KISS image through the IAC, we can see all 4 nerves are present, including the cochlear nerve in the anterior-inferior quadrant. On the other hand, if we look at the CT image on the other side, you'll notice that we can't really identify an opening for the cochlear nerve at the base of the medialis, which should immediately lead you to question whether the cochlear nerve is actually present. And this suspicion is confirmed on the MRI. There's no nerve where the cochlear nerve should be, so what we have is a case of unilateral cochlear nerve deficiency. Posterolateral to the cochlea, we'll find the vestibule, which is an oblong-shaped cavity containing the utricle and saccule of the membranous labyrinth, which are structures involved in the detection of linear head acceleration. From the vestibule, we'll find arising 3 orthogonally oriented semicircular canals, which are involved in the perception of angular head acceleration. These include a horizontal canal, a posterior canal, and a superior canal, each of which contains its respective semicircular duct. Now, when you're evaluating the semicircular canals on MRI, make sure that they are completely fluid-filled and that you can follow them each continuously all the way around from one end to the other. If you can't, you may be dealing with a case of either an aplastic or a fibrosed or ossified semicircular canal. In addition, on CT, each canal should be completely covered by bone. Pay particular attention on your coronal images to the apex of the superior semicircular canal, which forms a small hump at the top of the Petrous ridge, known as the arcuate eminence. This is the location where you're most likely going to see semicircular canal dehiscence. The other place you'll want to look, particularly in patients with large epitympanic cholesteatomas, is at the apex of the lateral semicircular canal. And here are a couple of examples of semicircular canal dehiscence. The image on the left is a pushal view of a patient with superior semicircular canal dehiscence. Notice the loss of the normal bony covering of the superior canal at the arcuate eminence. The patient on the right had a huge attic cholesteatoma, and in this coronal projection you can see that the cholesteatoma has eroded the bone at the apex of the lateral semicircular canal. Now, as I mentioned before, our conventional KISS and Fiesta sequences don't allow us to distinguish between the perilymph and endolymph containing spaces. But as it turns out, there actually is a technique that you can employ to visualize the membranous labyrinth with MRI. This involves giving a patient IV gadolinium, waiting about 4 hours, and then imaging them with a 3D contrast-sensitive sequence, such as a FLAIR or a true inversion recovery sequence. The idea behind this is that contrast will normally diffuse slowly through the blood labyrinth barrier into the perilymph containing spaces over time. However, the endolymph containing spaces remain impermeable to the passage of the contrast. So this allows you, with enough of a delay, to acquire images in which the structures of the membranous labyrinth are actually outlined by gadolinium containing perilymph. These images in the middle slide are taken from a study published last year by a group in Belgium, incorporating this technique in patients with Meniere's disease. These are post-contrast FLAIR images. The case on top demonstrates a normal ear, while the bottom two sets of images are from patients with endolymphatic hydrops. Now on the normal image, we can see two dark structures in the vestibule, indicated by the white arrowheads. The anterior one is the saccule, and the posterior one is the utricle. Normally the saccule is smaller than the utricle, and the two together should make up less than 50% of the area of the entire vestibule. The images from the other two subjects demonstrate progressively increasing degrees of utricular and saccular enlargement. Notice also in the bottom example how we can see dilatation of scala media within the cochlea. This set of images is from the same article and better demonstrates normal and enlarged cochlear ducts. The normal cochlea is at the top. Notice in particular on the bottom image how well we can pick out the dark band representing the enlarged scala media in a patient with cochlear hydrops. Now the last set of structures I'll cover in the inner ear are the endolymphatic duct and vestibular aqueduct. The endolymphatic duct is one of the structures of the membranous labyrinth. It is essentially a small canal that joins the utricle and saccule and ends in a blind pouch known as the endolymphatic sac, which is located within the dura along the posterior wall of the petrous bone. The bony canal through which the endolymphatic duct passes is known as the vestibular aqueduct, indicated here by the orange arrow. The aqueduct courses from the vestibule to the posterior petrous surface, and in normal hearing individuals, the classic teaching is that the width of the vestibular aqueduct measured at its midpoint in the axial plane should be no more than about 1.5 millimeters, or roughly the width of one of the nearby semicircular canals. Enlargement of the vestibular aqueduct, as we can see in this example, is among the most common abnormalities seen on CT in children with congenital sensorineural hearing loss. Now, some studies suggest that the upper limits of normal for the width of the vestibular aqueduct in children should be closer to about 1 millimeter. And keep in mind also that if the semicircular duct is dysplastic and enlarged, that you won't be able to use it as an internal reference standard to rule out vestibular aqueduct enlargement. That said, if the aqueduct is larger than the adjacent semicircular canal, it's going to be too big. On MRI, we should normally not be able to see the endolymphatic duct or sac, even on a high-resolution steady-state sequence like this KISS. So as a rule of thumb, if you can see the endolymphatic sac on MRI, as we can in this case along the posterior aspect of the temporal bone, it is going to be too big. For our final topic, I just want to briefly touch on the petrous apex, which essentially refers to the pointy, pyramid-shaped region along the most anterolateral aspect of the temporal bone in front of the otic capsule and the IAC. It's bordered anteriorly by the greater sphenoid wing and medially by the sphenoid body and clivus. Along with the rest of the petrous bone, it contributes to the floor of the middle cranial fossa and to the anterior wall of the posterior cranial fossa. Unlike the other parts of the temporal bone that we've already covered, the petrous apex, though, doesn't actually really do much of anything. Its clinical relevance primarily lies in its proximity to a number of crucial structures in the middle skull base, including the internal carotid artery, which runs right through the petrous apex, as well as the cavernous sinus and Meckel's cave, which are home to several cranial nerves, namely cranial nerves 3 through 6. This is an axial post-contrast KISS image, which I think very nicely depicts the relationship of the petrous apex to some of these structures. Meckel's cave resides just superior to the petrous apex and is home to the trigeminal ganglion. Just medial to this, we'll find part of the posterior portion of the cavernous sinus and the cavernous ICA. And if we look just posterior to this very closely, we can see also a small dot here along the posterior aspect of the petrous apex, which represents cranial nerve 6, just distal to where it pierces the dura at Dorello's canal. So because of these anatomical relationships, not surprisingly, patients with diseases originating in the petrous apex, be it petrous apicitis, a cholesterol granuloma, or a tumor, will frequently present with cranial neuropathies. The last thing I want to cover today is a normal anatomic variant of the petrous apex that can sometimes be mistaken for pathology. Now, it's quite common for the petrous apices to be pneumatized, and in fact, roughly a third of people will demonstrate some degree of petrous apex pneumatization on imaging. In most cases, that pneumatization will be symmetric. However, in about 5 to 10% of cases, we may see asymmetric pneumatization, in which one side is pneumatized and the other side is not. Now, because the normal yellow marrow in a non-pneumatized petrous apex is intrinsically bright on T1-weighted images, if you're not careful, you can actually fall into the trap of misdiagnosing the non-aerated side as a cholesterol granuloma. And unfortunately, we've actually had some cases in which patients were referred to our skull-based surgeons from outside for management of a quote-unquote cholesterol granuloma, when in reality all they had was asymmetric pneumatization of their petrous apices. Now, the clues that you'll want to look for to tell you that you're dealing with a non-aerated petrous apex rather than a cholesterol granuloma are, first of all, the absence of bony expansion or remodeling, preservation of some of the low signal intensity internal trabeculations, and signal dropout on your fat-suppressed sequences. Cholesterol granulomas will not suppress on a fat-suppressed MR image. If in doubt, you can also get a CT to confirm your suspicion. So I'll finish up by summarizing with just a few take-home points. We covered the 3 different functional units of the temporal bone, starting with the outer ear, which is made up of the auricle and EAC. Remember that the EAC is itself divided into a lateral cartilaginous portion and a medial bony portion. In the middle ear, we covered the ossicles and their order of conduction, which you can easily remember with the mnemonic MESO, short for Malleus, Incus, Stapes, oval window. Remember to pay attention to Prussak space, which is the most common location to find acquired middle ear cholesteatomas. And keep in mind and be able to identify the 3 normal soft tissue structures of the middle ear, namely the facial nerve and the 2 middle ear muscles, the Tensor Tympani and the Stapedius. In the inner ear, we covered the 2 major parts, the bony labyrinth and the membranous labyrinth, which are separated by the perilymph containing space. The bony labyrinth includes the cochlea, which contains the cochlear duct, the vestibule, which houses the utricle and saccule, the semicircular canals, which contain their respective semicircular ducts, and the vestibular aqueduct, which contains the endolymphatic duct and sac. Finally, we touched on the petrous apex, which is a close neighbor to several important structures, including the cavernous sinus and Meckel's cave, as well as all of the cranial nerves that pass through them. And finally, don't fall into the trap of misdiagnosing asymmetric petrous apex pneumatization as a cholesterol granuloma. So that concludes our tour through the temporal bone. If any of you have any questions after today's webinar, please feel free to shoot me an email at this address. I'm always happy to talk about the temporal bone. Thank you all for tuning in.
All right, thank you very much, Ben. That was an amazing talk, and it's a pretty complicated topic for most of us, and you really broke it down very nicely, and I hope it has demystified this topic for a lot of people. I'm just gonna go over the quiz cases first, and then we'll go back to Q&A. So please keep putting your questions in for us in the chat box and the Q&A area, and I'm just gonna go over the quiz questions now. All right, so moving on to our first quiz case, which was, I had these arrows, which were pointing to specific structures. So after Ben's talk, I think this should be fairly evident. He actually did hit upon these structures. So this first arrow is pointing at the malleus. It's the more anterior of the ossicles, and this is the neck of the malleus. And the second arrow is pointing at the oval window, which is where the footplate of the stapes inserts. And moving on to, there are some other little channels that, you know, I thought might be interesting for everybody to sort of be aware of. You know, there are all these little channels in the temporal bone, and you don't know whether you're dealing with a fracture, especially in the trauma situation. And so just to recap, you can have fissures and channels. And the fissures could either be extrinsic, i.e. fissures between the temporal bone and the surrounding bones, or they could be intrinsic fissures within the different parts of the temporal bone. So just looking at some of the extrinsic fissures, this is a spheno-squamosal suture. It's between the sphenoid and the squamosal portion of the temporal bone. This is petro-occipital suture. And this is the occipitomastoid suture. And I've seen these being called fractures. Moving on to the intrinsic fissures, you can have you know, the Kerner septum, you can have petromastoid suture. This is a suture right at the posterior margin of the EAC, which I've also seen being called fracture. And this is the tympanosquamous suture. And along the anterior margin of the EAC, anterior-superior margin of the EAC, is the suture called the Retrotympanum suture, which is where the chorda tympani is going to travel. Sometimes I've seen diastasis of the suture in fractures, and so that can be a little tricky. So just something to look for. And then in terms of intrinsic channels, you know, Ben talked about a lot of them, but you know, just a few more. So this is your classic singular canal, extending from the IAC to the vestibule, the back of the IAC, and this contains the singular nerve. This is the cochlear aqueduct, which houses, you know, this is basically the bony cochlear aqueduct going towards the basilar turn of the cochlea. And superiorly at the Petrous apex, often we will encounter this channel called the petromastoid canal, or the subarcuate canal, which contains a usually a venous structure. So with this knowledge, we can move on to my second quiz case, which was a little slightly more challenging. And this is another tiny little channel that we see all the time. And nobody really cares what it is or pays attention. But I figured that, you know, I saw a recent case which sort of prompted me to show this. So this is a channel going from the pars nervosa towards the hypotympanum. And if you notice on the axial, it's traveling posterior between the carotid artery and the jugular vein. And this is a classic channel, and it's called the inferior tympanic canaliculus. I know a bunch of you actually got this right, so kudos. And so the two normal structures that travel through this are the Jacobson's nerve, which is the tympanic branch of ninth nerve. And you can see this is the ninth nerve right here. And this Jacobson's nerve arises from the inferior ganglion of the ninth nerve and then enters the hypotympanum through the inferior tympanic canaliculus. The other structure is the inferior tympanic artery, which is a branch of the ascending pharyngeal artery, which again enters the temporal bone through this channel. So the next question is, what would cause these to become enlarged? So we know the normal structures, we know there's a vein, and we know there's an artery. So if you have an abnormality of these, then they can sort of become enlarged. So let's talk about the first one. So this is your classic vascular anomaly, which causes enlargement of the inferior tympanic canaliculus. So you can see this is an aberrant ICA, in which there's absent vertical ICA. And because of that, there is this collateral circulation which develops between the inferior tympanic artery, which is the branch of the ascending pharyngeal artery, and the caroticotympanic artery, which is, you know, in primitive embryologic times was also termed hyoid artery. And they sort of like become, you know, one and join together. And so the course of this artery is traveling through the middle ear. So what we're dealing with here is not the vertical carotid artery bony canal, but in fact is the enlarged inferior tympanic canaliculus. And this is the other structure, other lesion that can occur is a schwannoma of the Jacobson's nerve. So this is a good example from the literature. You can see there's a mass on the cochlear promontory, and you know, you would not be you know, faulted for calling this glomus tympanicum. So you know, the good thing here is that you can actually see enlargement of this canal. So this is a schwannoma of the Jacobson's nerve. So with that, I am going to get back to the main Q&A and chat portion. And let's see if we have Q&As. Let's see. So first question is for Ben. How do you interpret clinically presence or slight visibility of the endolymphatic sac or duct on MRI?
You know, in my own personal experience, if I can see the endolymphatic duct or sac, I generally will call it too big. Almost all of the patients that we image with KISS imaging through the temporal bones are going to be for hearing loss. And so if I can see them, generally I'll say they're enlarged. I don't know that I can recall a single instance in which I saw an enlarged endolymphatic sac or duct on MR in a normal hearing ear. I don't know, Dr. Moonis, if you have any thoughts on that.
Yeah, I agree. I've never seen that. So
so I mean, generally I tell my residents, if you can see it, it's too big.
Okay, and then another question along the same lines is, does the endolymphatic sac communicate with CSF in the subarachnoid spaces?
No, it doesn't. The endolymphatic sac is actually an extradural structure, right? So it's entirely basically between or within the dura along the posterior aspect of the Petrous canal. Sometimes, you know, in patients with endolymphatic hydrops, they will decompress the endolymphatic sac, but normally it should not connect with the CSF at the posterior dura. There is an aqueduct more inferiorly, the cochlear duct, which I can't recall if Dr. Moonis showed it in one of her slides,
yeah,
which does communicate with the subarachnoid space, but that's more inferior at the level of the jugular fossa.
Great. Another question is about bony coverage of the facial nerve. How do you assess for that? And, you know, that's the bane of our existence.
Yeah, I mean, the classic teaching is, you know, a patient with a cholesteatoma, you know, if the facial nerve is dehiscent, you should call it. Unfortunately, in my own experience on our CTs, it's often, probably more often than not, that I can't even see the covering of the facial nerve, even in a normally aerated temporal bone where there's like nothing there. So if a patient has a cholesteatoma or some sort of a mass that's right up against the facial nerve canal and I can't see the bony covering, honestly, I have no idea whether or not that covering is dehiscent or not. I think the only thing that we can say in those instances is that we can't visualize the bony covering. I wouldn't call it dehiscent because the surgeons may go in there and they'll find that the bony covering is completely intact. We just can't resolve it by imaging. But I wouldn't go so far as to say that it is clearly dehiscent. I'll just say that you can't visualize the bony covering. And if you want to say, you know, it could be dehiscent, that's fine. But in my experience, I think it's really hard to make that call.
I agree, Ben, because that's what I do in my reports. When there's extensive cholesteatoma, I just warn the surgeon that, hey, I can't really see the bone. You know, it could be that the nerve is floating freely within the cholesteatoma, so that they're like careful when they're going in.
And I find that's also the case wherever you have thin bone in the temporal bone. So for instance, tegmen dehiscence is also something that I have a very, very difficult time like confirming or ruling out unless it's an obvious giant hole in the tegmen, because oftentimes even, you know, in a normally aerated middle ear and mastoid, you will see these apparent areas of discontinuity along the tegmen, which in reality aren't really areas of dehiscence. It's just the bone is very, very thin.
Great, great. And yeah, I think in terms of dehiscence of the facial nerve, I've seen it in maybe one or two cases in my career where I saw dehiscence, which was touching the oval window and touching the stapes and causing hearing loss. But it's a very uncommon sort of presentation when you see a dehiscent facial nerve.
Yeah, and in those instances, sometimes you can actually see the facial nerve like sort of drooping down from where it normally should be in its canal. And that's really the main clue that there potentially is dehiscence, that the facial nerve is actually, you know, herniating outward. But if it's like normal in position, normal in size, it's really hard to call.
Our next question is, what investigation of choice do you recommend for necrotizing otitis externa? And what do you look for, please?
Oh, goodness gracious me. I always get asked this question by the ID docs. And honestly, I don't know that I actually have a one good answer to that. Each of the different modalities, be it CT or MR or nuclear medicine studies, like either a bone scan or a white cell scan, have their role, I think. Most patients initially will probably get evaluated with either a CT or MRI. Unfortunately, in early cases of necrotizing or malignant otitis media, the signs can be very, very subtle. One of the things that we look for is the retrocondylar fat pad. So normally if you look, and I wish I had an image of this, but normally if you look at the external auditory canal, where it is abutting the mandibular fossa, there should be a pad of fat that you can see both on CT between the EAC wall and the condyle. So that's the retrocondylar fat pad. And typically one of the earliest findings that you'll see in necrotizing otitis externa will be sort of stranding or haziness or loss of that, that fat pad. Things like, bone destruction are pretty late findings, so I don't really rely on that. And of course, if you see enhancement of the bone of the Petrous apex or inflammation or enhancement of the soft tissues adjacent to the Petrous apex at the skull base, those are all, classic findings. If in doubt after CT and MRI, I think nuclear medicine imaging is warranted. Probably I would start with a bone scan in those instances. The classic teaching is you diagnose with a bone scan, but then you follow up with a tagged white cell scan because the findings sort of in the chronic phase after the patient has been on antibiotics can still look very, very ugly on CT and MR and bone scan. So those are not going to be very specific in the non-acute setting.
Right, and to add to what you're saying, Ben, in terms of which is the preferred diagnostic modality, I think most patients actually get T-bone CTs as the first. If they're presenting the ER, that's their first modality. But I often recommend getting an MR because I think they're both complementary, and I think you see a lot more soft tissue involvement with MRI.
Yeah.
So and especially if you're looking for like dirty fat in the parapharyngeal space, I kind of like MR for that. So yeah, I end up, recommending both at some point. They get both. And like you said, for nuclear medicine follow-up at our institution, we use gallium scan.
Yeah, gallium.
And that's the other thing to be used.
And to piggyback on what you just said, I agree. So whenever we suspect malignant otitis, we will recommend an MRI. The important thing about CT is if you are going to do a CT, oftentimes I know when, people do temporal bone CTs, they only send bone windows, which are very noisy. I think it's important to make sure, if that's the suspicion, that you also have a good set of soft tissue kernel reconstruction so you can actually look at the fat in the retrocondylar region.
Absolutely. That's a very important point. And I bug my fellows all the time. When we're reading anybody for NOE, I'm like, you have to I need a coronal soft tissue window in which I can see both TMJs at the same, same section. So that's a great point. Next question is, Dr. Huang, do you use 3D FLAIR for cochlear eye drops? Is 1.5T enough, or do you need 3T? I guess that's the other question.
Yeah, so I think, this technique is one which I think is still very investigational, and there are not a lot of people that do it. Honestly, at UNC, we don't do it. We've tried it, and the results were less than stellar. But if you look at the literature on it, I think basically all of them have used 3T because these sequences are very, very signal starved. You need a lot of signal. And so looking at the papers, you'll see that when they used just a head and neck coil, these scans took on the order of 15 to 20 minutes. They're very, very long scans. So if you're going to do it, I think you have to use the highest field strength 3T that you can.
And I agree with you, Ben. I mean, I think it's kind of problematic to expect a patient to come back in 4 hours. I think it's just not a very practical solution. But so we don't do it. And also, GE doesn't have a great sequence yet for 3D FLAIR. I mean, I think it's just, and we're pretty much a GE shop. So I know like Siemens and Philips have better solutions. So we don't do it either, but I do know in Europe, Bert, and I think in England, Dr. Vedyanathan, they're all doing it. So I think it's certainly a good technique in the right hands, I would say. Next question is, what are your thoughts on cone beam CT and multi-detector CT for temporal bone?
I think they're both great. I actually personally, I actually like cone beam CT. Some people don't like them because they tend to be a little bit noisier than a multi-detector CT, but the resolution on cone beam CT I found is actually superior to what we can get on a multi-detector CT. If you have it, use it. I think the images look great. I don't really necessarily prefer one over the other for general purposes.
Right, and then I think people are answering this question. What was that? So there's a question of, do you just rely on standard projections, or do you do your, just do axial or coronal? Do you do other projections too?
So I think this varies from practice to practice. I know that Dr. Moonis and I were actually talking earlier today, and they routinely do additional sequences. We basically just rely on axial and coronal CT in the vast majority of cases. We don't typically have our technologists perform additional reconstructions. Rarely, if I want to, I will sort of reconstruct them myself on the impact station. But I think in the vast majority of cases, coronal and axial images are what we do.
Right. Any clues on how to best assess for ossicular chain demineralization?
Oh, goodness gracious me. Honestly, that's not something that I've thought about. I presume you mean like in the setting of like resorption of the distal long process or things like that. Not really. I mean, if I can see it, I think it's okay. If I can't see it, then, I question whether or not there's been resorption. And, in those instances, they're using additional reconstructions may be helpful. So if you can lay out the entire length of the Incus long process to where it articulates with the Stapes, that can be helpful if you have a question. But I think that in most cases, you're able to, if you can follow the ossicular chain, from start to finish, you should be, pretty well off. And I think that you can see those things on just your traditional axial and coronal images.
Right, and I think, we had this discussion earlier, and I actually love the Poiseuille's view for the ossicles. So Poiseuille's is traditionally been done for covering of the superior canal. But I think it gives a beautiful look at the long process of the incus, lenticular process, and the incudiostapetal joint. So, if I suspect that there is some ossicular abnormality on the axial and coronals, I always go to the Poiseuille's to help with problem solving. So just another sort of, technique that you have in your back pocket. It's the images are all there. You just have to reconstruct them. Do you question the presence of possible superior semicircular canal dehiscence on IAC MRI routinely?
On MRI?
Yeah.
Oh no. I don't think that we can see. I don't think that we can see the bone overlying the superior canal on MRI well enough to call it.
I agree. I mean, back in the in the past, when in earlier days of MRI, I was overcalling those like crazy, and turns out that they all turned out to be, not real. So I, definitely, unless it's like very, very striking, I do not call superior canal dehiscence on IAC MRI. Okay, let's see. There's a question about otospongiosis, which we may leave for next time. Dr. Pinelli comments that if you do cone beam CT, you never want to go back to MDCT. I kind of agree, because at Mass Eye Near, it was, I was exposed to those and beautiful images for sure. Let's go to, let's see. Does the endolymphatic sac communicate? No, we already talked about that. And somebody actually asked another question. Does the endolymphatic sac have perilymph? I guess there's still some confusion about the contents of these things. So
no, the endolymphatic sac is one of the membranous structures, right? So those all contain endolymph.
Okay, all right. So Francis is asking for a relationship of the Retrotympanic suture and the tympanous squamous suture line. I think we'll have to probably do that in real time. So maybe we can take that offline, Francis, if that's okay, because we need to scroll through to sort of help with that. Let's see. Sanjay Prabhu says, regarding enlarged vestibular aqueduct in patients without diagnosed hearing loss, I have seen this in MRI brain studies in at least a couple of patients scanned for developmental delay without diagnosed hearing loss at the time. Hearing loss in EVA patients can be intermittent, and degree of the hearing loss in patients with EVA can vary from normal to profound, and the hearing loss can be fluctuant. So I guess, you know, it's just essentially saying that, you know, you can have EVA and, you know, and it can just be the first sign that the patient may have hearing loss. So maybe we should not dismiss, I mean, I guess, an incidental enlarged endolymphatic duct. And Christine Glastonbury comments that I never read T-bones without making stenwords and partials. And I kind of agree with you. We get partials and everybody. Stenwords I find less useful, but yeah. And Phil Chapman says many ENTs are now requesting these views, and I have to agree. At my institution at Columbia, you know, our otologists routinely want, you know, the sagittal obliques or partials.
Are those mainly for semicircular canal evaluation, or do they like them?
Yeah,
for,
yeah, that and vestibular aqueduct. So Amy Giuliano had, you know, published this paper on measurements of the vestibular aqueduct at the midpoint on the sagittal oblique, and you know, those were some very compelling results. So, you know, and I agree. I think you see the vestibular aqueduct in just basically one plane. In one shot, you see the entire vestibular aqueduct and on an oblique, on a sagittal oblique or in a Porcell's view. And I think that's really nice. Let's see. And then actually, Rich Reagan says that he does short and long axis projections in all cases, which I believe he is, I think he might be referring to the Ossicles, because there have been a few papers in ASHNR about doing these sort of more dedicated problem-solving double oblique projections to look at the Ossicles. We can send you guys a link to those papers. So, you know, I think that's, you know, something that if we have time, it's actually nice to be able to do that. And we have to stop naming stuff after dead people. Correct, Rich? So I think we're probably kind of running out of time here. So at this point, I will go ahead and, you know, call this meeting to close. Thank you, everybody, for attending our first webinar. And a lot of people attended from, you know, international locations. So thank you for that. Just again, a reminder, please do register for next week's webinar. It's going to be a really awesome one. It's Dr. Hugh Curtin, amazing speaker. And he's going to be talking about conductive hearing loss, and you really wouldn't want to miss that. And also, please keep sending those abstracts for ASHNR virtual meeting. It's going to be an awesome meeting this year. So with that in mind, thank you, everybody. Thank you, Ben. It was an amazing talk.
I'm just answering some questions online.
Yes, please.